expecting some more people? No? Okay. Chalo, start
Good morning everyone. I am Dr. Nsh-ICU, RMO in Neuro-ICU. Today I am interested with the topic of diabetic ketoacidosis and hyperosmolar hyperglycemic state. I'll right away jump into the topic. So I'll start with a case, a 30-year-old male with type 1 diabetes mellitus since the age of 14 years. He was brought to the emergency for drowsiness, fever, cough, diffuse abdominal pain and vomiting. On further examination, we find out he was on insulin glargine 24 international unit at bedtime and rapid acting insulin before each meal. He was tachypnic, confused with the vitals as in pulse 100 and 100 per minute, BP 100 by 60 millimeter of mercury. He was dehydrated. ABG is as follows with a pH of 6.9, PO2 of 95, PCO2 28, bicarb 3.9, sodium 152, potassium is 5.3 and a CBG of 346. So with that we can conclude that the patient is a case of diabetic ketoacidosis. No. I think it's going towards the diagnosis of diabetes.
Go back to the slide.
Yes, sir.
So, what does the ABG tell you?
He has acidosis, metabolic acidosis.
Okay, but 6.9 is severe metabolic acidosis. And how do we normally classify metabolic acidosis? In terms of anion gap?
Yes.
Are you aware? White anion gap acidosis,
Yes.
normal anion gap
Yes, sir.
acidosis.
Yes, sir.
So how do you calculate anion gap?
Sodium minus chloride plus bicarb.
Okay, but chloride is not here.
Yes, sir.
Even if you presume if it is normal chloride. What is normal chloride? Normal chloride. Let's say 100.
Yes.
Okay. So sodium chloride of 100 and bicarbonate of 4. So 104. So what is the anion gap?
Sir, can you please repeat?
Sodium is 150, say.
Yes, sir.
And chloride is 100.
Yes, sir.
And bicarbonate is 4.
Yes, sir.
So what is the anion gap?
100 plus 4 minus 150 is 84. What?
Quite a bit. 45
Yes, sir.
Yeah?
Yes, sir.
So what is the normal anion gap?
Anion gap is 7 to 12.
So you see the question is whether you take potassium into consideration or not. So that whatever, but 40 odd is like very high anion gap. So what are the causes of high anion gap acidosis, metabolic acidosis? So one of them is diabetic ketoacidosis. Let's say renal failure.
Yes, sir.
It can be so. This chap has had diabetes for a while. He's 30-odd-year-old. We don't know how good his control has been. So he could well be.
His BP is low.
He could well be in renal failure. So we don't know his crafting there. Second is, he's a young fellow who's had a chronic illness and, his life has been turned upside down. So maybe he's taken some sort of an overdose. You don't know.
Yes,
So
sir.
that could be a cause of his metabolic acidosis. And he's unwell, confused, tachypnic, etc. So he might just be septic,
Yes, sir.
with organ failure, hypotension, renal impairment. So this would be lactic acidosis. So to see that this is diabetic ketoacidosis, you have to establish that he's diabetic. That's from the history, and you've got his CBG, and then you have to demonstrate ketosis. The ketosis. So you haven't demonstrated ketosis here yet.
Yes, sir.
So yes, this is very likely to be TK, but you have to have another
Urine keto.
urine ketone, blood ketone, water. Okay, carry on.
Yeah, so the ketone body.
Yes, sir. Urine ketone should be
How
like
much will it be?
+2 more than.
Sorry?
Urine ketone more than +2, 160.
Yeah, so it will generally be moderate to large.
Yes, moderate to large.
Yes, sir.
Why mildly cannot? That's really just using it. It's just to make you think.
Yes, sir.
Mildly cannot.
Sir, there might be other cases of ketosis.
So if
Starvation
not
ketosis.
eaten and not been drinking, maybe had some vomiting,
Yes,
and
sir.
you could have a little bit of ketosis.
Yes, sir.
So you need to have some significant amount of ketone. Right, okay.
Diabetic ketoacidosis is a hyperglycemic emergency which is characterized by these three criteria, which is hyperglycemia with a plasma glucose of more than 13.1 millimole per liter, acidosis with a venous pH of less than 7.3, ketosis which can be ketonemia or ketonuria. Ketonemia is more than 3 millimole per liter, where ketonuria is more than 2 plus, which is like moderate.
তোমাদের জিজ্ঞেস করি তিনটে ক্রাইটেরিয়াই থাকবে
No, sir. CBG, blood glucose is there, acidosis, pH 7, less than 7.3, ketosis are more to and black more than 12.
না এই তিনটে থাকতেই হবে
ADA guidelines are as per 5 points.
না আমি আরো দুটো তিনটে চারটে যাই থাকুক কিন্তু এই তিনটে থাকতেই হবে মানে do you have to have ketosis? Yes, we said acidosis, okay. Do you have to have
Euglycemic.
That is right. So this is
Euglycemic.
something which we are now seeing because
Maybe you
No.
SGLT2, SGLT.
If the patient,
especially the SGLT
inhibitors, yes, sir. And
সুতরাং yes, this is the standard classic
Yes, sir.
definition.
Yes, sir.
But ওটা খেয়াল রেখো
yes, sir.
normally কি হয় a sick patient comes to the ICU and everybody gets a CBG, so CBG sugars are high.
Then we put
Everybody
in
gets
an
an EBG.
insulin.
There's metabolic acidosis. Immediately the
Immediately
it clicks in the brain that that a decay so you do
So history of diabetes perhaps is also
is
Yeah. And sometimes if the person is a known case of diabetes, so if he has a sick period and he's being brought to the hospital, most of the times they put in en route insulin, so the sugar will come down and he will come with a decay, ketosis and all, but his sugar will be less, so will be like euglycemic decay.
the history of diabetes is important. So
Yes.
if you don't have hyperglycemia, but somebody is known to have diabetes, as Dr. Gupta was
Yeah.
saying, and then his glucose might be normal because he's been put on an SGLT2 inhibitor.
Yes, sir. Yes, sir. So moving forward to the next case, he's a 64-year-old man and is a known case of type 2 diabetes mellitus and was brought to the emergency with confusion, extreme thirst, frequent urination, and he had an episode of fever and cough. Further examination, he was on oral anti-diabetic drug which he had discontinued for 5 days. He was bedridden due to sickness for past 1 week. EBG is as follows: pH 7.45, PO2 is 98, PCO2 is 40, bicarb is 15, sodium is 150, potassium is 4. Blood sugar is 650 milligram per deciliter. He was severely dehydrated, mentally confused, and urine ketones was not significant. So we are thinking it towards a hyperosmolar hyperglycemic state, which is also a metabolic emergency and is characterized by all these following criteria, which are hyperglycemia. It has to be more than 600 milligram per deciliter.
just like পেছনে চলে যাও
Yes.
just so তুমি এই এবিজিটা দেখে তোমার কি মনে হবে
So more or less এটা ঠিকঠাক কি আছে।
ঠিকঠাক আছে বা কার্বোনেটটা
পনেরো আছে।
আচ্ছা bicarb is more, হ্যাঁ স্যার।
তাহলে ওটা কি বলা হয়
Alkalosis.
হ্যাঁ
Alkalosis.
অ্যালকালোসিস কেন অ্যালকালোসিস কেন বলছো পিএইচটা ঠিক আছে স্যার
হ্যাঁ, স্যার।
বাট বাইকাপটা কি আছে সো হাউ ডু ইউ ইন্টারপ্রেট দিস এবিজি বলো
Sir, respiratory alkalosis composite.
respiratory alkalosis the বাইকাপটা কি লাগে বাইকাপটা কম কেন
And compensate mechanism
so primary pathology টা কি
metabolic acidosis. I mean,
Metabolic
acidosis. acidemia.
Okay, whatever, ঠিক আছে, মানে bicarbonateটা কম আছে, so that is definitely an issue. There's an acidosis of whatever type. And then the CO2 is a little bit, but CO2 কিন্তু এই values গুলো ঠিক match করছে না। এটা combination
is not a valid evidence.
আর একটু কম আপনার
এই আচ্ছা, আর তুমি এই যে সঙ্গে সঙ্গে হাইপারঅসমোলারের কথাটা ভেবে নিলে,
Yes, sir.
হাইপারঅসমোলার কিভাবে ভাবলে এইটাতে এই ভ্যালুস গুলো দেখে, মানে what is normal osmolality তাহলে জানতে হবে।
what's the calculated osmolality in this?
এখানে
sir.
What is normal osmolality?
Huh.
And in this patient, what is the calculated osmolality?
patient osmolality,
Because you are saying that there is a
Not everything is given over here. I should have known the bun also to
ঠিক আছে,
correct the osmolarity.
নরমালও ধরে নাও, মানে নরমাল হবে না,
Normal.
how do you calculate?
There's a formula which is 2 into sodium plus glucose by 18 plus bun by 28.
Glucose by 18 টা কেন করা হয়? মানে শর্করা কিন্তু তোমাকে একদিন কেটে আনতে হবে।
Yes, so millimoles. Millimoles. Millimoles से नहीं आता है।
So basically, ঠিক আছে, 2 into sodium বা potassium আবার যদি নাও, so তাহলে 150 plus 4, so it's 154, so it's 308, তাই তো, ডাবল করলে তাই না হয়, প্লাস এই 650 divided by 18, তুমি ধরো divided by 20 করে নাও হিসেব সুবিধার জন্য, তাহলে কত দাঁড়াবে? about 30 order,
33.
তাহলে it is already 330 340 মতো দাঁড়িয়ে গেল। তারপরে ইউরিয়াটা যদি থাকতো, we could have added or given যদি থাকতো, তাহলে we could have added. So what's the normal osmolality?
320 less 320 million
320
less than 320.
না, normal osmolality কত?
280 to 290.
Yeah, roughly
Just
about.
under 300.
So that definitely there is significant. তুমি যদি দেখো এই সবকটার মধ্যে the biggest normal component is sodium. ঠিক আছে, তুমি এখানে দেখছো সোডিয়াম যেই বাড়বে তারপরে তোমাকে ওটাকে ডাবল করতে হবে, তাহলে হাইপারঅসমোলার হয়ে যাবে, প্লাস সুগারস বাড়লেই ওটা it will contribute. These are the two big ones. So somebody with a sugar of 650 and a sodium of 150, they will be hyperosmolar. Right?
Yes, sir.
I have an issue with the sugar of 650 and sodium 150. What does that signify?
1%.
Corrected sodium, so 1.65 sodium correction is 100 milligram or 100 gram per DL.
100 sodium?
1.65 per gram. Sorry, কমে যাবে। মানে corrected sodium করতে হবে।
তো এখানে অনেক বেশি রয়েছে, it should be ideally somewhere around 120, এখানে 150. What does that signify?
Dehydration, severe dehydration.
Okay. HHS is a metabolic emergency which is characterized by hyperglycemia, which is more than 600 milligram per deciliter, hyperosmolarity, no ketoacidosis, commonly in type 2 diabetes mellitus, and severe mental confusion and hallucinations are also noted. Symptoms, so which are common to both HHS and DKA are polyuria, polydipsia, weight loss, vomiting, dehydration, weakness, Kussmaul's breathing, which is mostly seen in DKA, tachycardia and hypertension. HHS, and there are some dissimilarities between HHS and DKA. HHS develops over a couple of days a week, and DKA is an acute episode. HHS is mostly commonly associated with type 2 diabetes mellitus, while DKA is more commonly seen in type 1, but it can also be seen in type 2. This is the sign and symptoms of both DKA and HHS, with polydipsia, headache, low GCS, coma, confusion and seizures, nausea, vomiting, abdominal pain, tachycardia, hypertension, dehydration, polyuria, cramps, and urea, oliguria is also seen. So coming to the next topic is pathogenesis of both DKA and HHS, which is mostly similar, and the triggering factors being stress, infection, and insufficient insulin. So if we start with DKA, DKA is due to absolute insulin deficiency, and due to which there is impaired glucose utilization, And also there is an increase of counter-regulatory hormones like growth hormone, cortisol, glucagon, catecholamines. Due to decreased glucose utilization, the body tries to compensate the energy by lipolysis, and which will lead to increase in the fatty acids in the liver, which will ultimately contribute to the formation of ketone bodies. Due to increase in the counter-regulatory hormones, there will be increased protein breakdown, and these will ultimately lead to the formation of gluconeogenic substrates, which will increase in cause neoglucogenesis and glycogenolysis, and this will contribute to hyperglycemia. When the body has increased amount of glucose, it will try to excrete it out through the process of osmotic diuresis, which is also which will cause glycosuria, and there will loss of water and electrolytes, and this will cause the dehydration component of in both the cases. In case of HHS, whatever is different from DK is all mostly similar. The only part which is different from DK is that there is relative insulin deficiency. So there is increased amount, there is impaired glucose utilization, which is leading to hyperglycemia, but the sufficient amount of insulin is there, which is not allowing the formation of ketone bodies. So this is the overall pathogenesis, sir. The precipitating factors. So infection being one of the most important, like pneumonia, UTI and sepsis. If we discontinue a person who is already on insulin and he is discontinuing it, or there is an inadequate insulin administration, pancreatitis, myocardial infarction, CVAs, drugs like corticosteroids, thiazides, sympathomimetic, pentamidine and antipsychotic drugs. Laboratory diagnosis. So the key diagnostic criteria for DK is the elevation of circulating ketone. Mostly beta hydroxybutyrate is the main metabolite. Nitroprusside test is done in both urine and serum. It is a semi-quantitative test and it measures acetoacetate and acetone, and hence it's not quite effective in diagnosing the severity of the DK. Hyperglycemia is another component, diagnostic criteria. For DK is more than 250 milligram per deciliter, and for HHS is more than 600. However, in some cases the blood glucose is less than 250 or 13.9 millimole, and this is known as euglycemic DK. So we'll quickly take a look at the causes of DK, euglycemic DK. These are those patients who have received insulin en route to the hospital, type 1 diabetes mellitus who are young and vomiting, low caloric intake or starvation, depression, pregnancy and SGLT2 inhibitors. These are the, this is continuing with leukocytosis can also be seen in DK and HHS, but it has to be, it lies between 10,000 to 15,000. If it's more than 25,000, we can say it's sepsis. Serum sodium is low because osmotic flux of water from intracellular to extracellular space in presence of hyperglycemia. Serum osmolarity is more than 320 millimole per liter, is linearly proportional to stupor or coma. Serum potassium, due to decreased insulin, there is extracellular shift of potassium and thereby causing its elevation. Hyperphosphatemia is also seen. Hyperamylasemia is seen in 27 to 79% cases of DKA. You might confuse it with pancreatitis, but no, it's not that. So this.
Where is this amylase from? DK.
Yes, sir.
That amylase is which one? It's not pancreatic. Where else can you get amylase from?
So I don't know, pancreas, in pancreas.
Pancreas, right?
Yeah.
Is there something called salivary amylase?
Yes, sir.
So in DK they say it's not pancreatic amylase, it is salivary amylase.
Okay.
So the phosphate could be other way, I think. Yeah. Could be underway. Okay. Good.
Sir, this is basically whatever I have said, it's written in the chart with diagnostic criteria both DK and HHS. Mild, moderate, severe, this is the DK part, and HHS. With plasma glucose in DK should be more than 250, whereas in HHS is more than 600. Arterial pH in case of mild DK is between 7.25 to 7.3. In moderate it's 7 to 7.24, whereas in severe it should be less than 7. In case of HHS it remains mostly more than 7.3. Serum bicarb lies between 15 to 18 in case of mild, moderate 10 to 15, and in severe it's less than 10, whereas in HHS it's more than 15. Urine ketones is positive in DK, and HHS it's present in small quantities. Serum ketones is positive in DK, but in HHS is again small. Effective serum osmolarity is variable in DK, where in HHS is more than 320. In ANGAP, it is more than 10 in mild, more than 12 in both moderate and severe, and less than 12 in HHS. Alteration in sensorium, alert in case of mild DKA, alert or drowsy in moderate. Stupor or coma is seen in severe and HHS. So this is another table differentiating between HHS and DKA, where we can see the glucose is in the range of 930 plus minus 83. Okay, so I'll straightforward go to the management. Management has been broadly classified in with fluid therapy being the most important, and the foremost thing which we should do: insulin therapy, potassium, bicarbonate therapy, and phosphate. Fluid therapy, it is directed towards increasing the intravascular, interstitial, and intracellular volume, which are all reduced in hyperglycemic crisis. In case of no cardiac compromise, and in case of low serum sodium, correction with normal saline at the rate of 15 to 20 milliliter per kg body weight.
9% normal saline correction is actually low compared to his serum sodium anyway. So there is no risk of you developing hypernatremia from your therapy per se.
Yes,
Okay, so that you need to be cautious about in practical terms. I know this is what is written in the book,
yes, sir.
but over the last 20 years of doing medicine, don't go gung-ho about the sodium balance early on, because such rapid shifts of fluid into the brain, generally most patients cannot take it.
Okay, sir. Yes, sir.
I mean, a lot of the hyperosmolarity is due to the sugar. Patients are dry as a crisp, is the phrase we use. I mean, the dehydration in HHS is much more severe than because those patients become iller. DK patients become iller early because of the ketoacidosis.
Yes.
Whereas these patients take a long time elderly, and they lose a lot of fluid, so either 8 to 10 liters fluid deficit easily over the body. So that is what's making them more hyperosmolar rather than the sodium. But
they've lost a lot of water, 8 to 9 liters. They've also lost a lot of sodium as well.
Yes.
When they are losing water. So just because of the dehydration, you are getting that mismatch in terms of serum sodium.
Yes, sir. In case of any cardiac compromise, monitoring of serum osmolarity, cardiac and renal parameters, and mental status is to be done. When the blood glucose reaches less than 200 in DK and less than 300 in HHS, the fluid is switched to 5% dextrose.
Why is that?
Sir, because when we are providing with regular insulin, we are giving regular insulin, which will cause hypokalemia.
It's slowly. You're going down the right track, but do it slowly. You can say no rush.
Yes, sir.
So what is the reason for doing the
Take two of them separate. So you take the DKA first. When the blood glucose reaches less than 200 in DKA, you want to switch off the fluid, which perhaps is normal saline you are giving.
Yes, sir.
Okay, and you want to switch to 5% dextrose. Why is that?
Because try করা উচিত না এটা hypoglycemia treat করছো with giving insulin তাকে আবার তুমি dextrose prescribe to some point of time that must be a reason.
Yes, sir. Yes, sir.
So we need to correct the acidosis in addition to everything else. When you're giving insulin infusion or whatever, and your sugar has come down, but your acidosis is not quite there yet. So you need to continue to treat the acidosis. And how do you treat the acidosis?
By giving insulin.
By giving insulin. But if you continue
But
to give
then it will
insulin,
cause hypoglycemia.
then the sugar will fall. So you need to provide the calories,
Yes, sir.
the glucose for the patient to.
Yes, sir. It's for the hypoglycemia.
You flush out ketone bodies.
Yes.
By giving insulin, এই যে তিনটে component of decay
Flush out and but to prevent synthesis.
তিনটে যে components এই বললেন না একটা diabetes মানে high sugar একটা ketone body
Yes.
আর হচ্ছে acidosis. So all the components if you start giving insulin the glucose comes down earlier than the other components.
Yes, sir.
Right?
Yes,
But
sir.
you have to continue insulin because this is the only anabolic hormone. In order to prevent lipolysis and proteolysis, the only drug available is insulin. Unless you use insulin, proteolysis cannot be stopped, reversed. The lipolysis cannot be reversed. The acidosis cannot be treated. So because you need to keep giving insulin for a longer period of time,
It will
because
cause
insulin
hypoglycemia.
cause hypoglycemia.
So we have to switch it with 5% extras. Yes.
Okay.
Yes, sir. So,
You haven't finished.
what, sir?
Go back again.
So I have put in a chart. So
You
I'll.
have to understand it. Chart हम लोग देख लेंगे बाद में. पीछे जाइए.
Yes, sir.
अभी HHS में if it is less than 300, you need 5% dextrose. Why is that?
So, 5% extras in it. Yes, sir.
আগে স্যার বললেন না যেটা ওইটাই করেছে এর আগে ডিসকাশন
Ketone negative.
না তার আগে অসমোলারিটি
Ah.
র্যাপিড কারেকশন অসমোলারিটি
We have to keep it between 200 to 300.
তোর পরে কমপ্লিকেশন লেখা আছে
Yes, sir.
Well, he's already giving you a hint. Come on, say it.
Sir, it will cause cerebral edema.
র্যাপিড কারেকশন করতে থাকে
Yeah. So okay, fine. So that's great. How do we treat cerebral edema?
Mannitol.
What does that do?
It will make the blood hyperosmolar and
Intravascular increase in osmolarity is what you want.
yes.
And how are we doing it?
How we do?
How are we doing it? You want to raise the osmolality. Is that the reason why you want to give 5% dextrose?
Yeah. Yes, sir.
Is that what you're trying to say?
Is that the direction?
Is that how? Is that truly exactly how we want to do it? এটা কোথায় থেকে নিয়েছে? হ্যাঁ? এটা কোথায় থেকে নিয়েছে কোথায় থেকে?
Sir, Kitabchi. Kitabchi, sir.
कौन सा किताब?
No, there's a reference of a
Reference?
Japanese guy called Kitachi.
Japanese. So, see, in HHS, as I was mentioning, it is the hyperosmolarity. You want to correct it slowly. So, suppose it is you are correcting it very quickly. You can either give somebody 5% dextrose, so you basically raise the blood sugar values. It is perhaps not what we do in India, at least. That is not the practice that we follow. What I was trying to tell you is that there is no rush to give hypoosmolar fluid IV. Don't give them the half-strength normal saline. Even 3% normal saline is something that you do to reduce cerebral edema as a
Yes.
clinical practice. So your sodium is if you keep it slightly high, your osmolarity is maintained. When Dr. Gupta mentioned to you early on, the doubling of sodium gives you the osmolarity value. So even a couple of 3-5 millimoles of sodium increase in circulation is going to give you that osmolarity. So what I prefer is basically you can keep the sodium slightly on the higher side, doesn't matter. Okay. But there's another option that you can perhaps also do it by giving somebody glucose as well. That will also perhaps maintain the osmolarity.
Actually, Manish, neurosurgeons, trauma, head injury patients and all, they hate 5D. Because 5D actually, when you give it, it is actually hypoosmolar at the end, because the glucose is metabolized and what you're left with is water.
Agreed.
So,
but in this state where insulin deficiency is there, then it is perhaps isoosmolar.
To start with 0.9% NS, followed by you can start 0.45. The whole idea is basically to correct intracellular dehydration.
Absolutely.
Right? So the question is the intracellular dehydration, why not 0.45 from the very beginning? That can be a question. But the issue is that the plasma osmolarity is very high already. So even on solution which is having osmolarity of 308 is enough to correct intracellular dehydration to begin with. Initially intravascular to correct high, then it gets intracellular to correct high. If you correct intracellular dehydration further, then you are giving a hypotonic solution
that is the
correct the intracellular dehydration, which is 0.45. But Dr. Sai is telling me there is no hurry, because if you do it, you might correct the dehydration, but it might also allow the extravascular, extracellular fluid to enter brain cells more.
Okay.
It's bound to happen.
Okay.
From the second a balance is probably is required. But you correct dehydration, but ensure that the reverse doesn't happen. Too much of entry of free fluid inside the brain cells
will go
is probably not something we look for as well. More than that is more than 50%. See, 0.9% যেটা NS, ওর osmolarity হচ্ছে 308, জানো তো এটা? 154 তো essentially যদি plasma osmolarity 280 to 290 হয়, যদি upper limit 290 হয়, we are using a fluid which is hyperosmolar to plasma. But in this case, in decay, the plasma osmolarity is on the higher side. Higher than 0.9%.
Yes.
That is why you can correct both intravascular as well as intracellular dehydration.
Okay.
But subsequently, in order to be aggressive enough, we use a hypotonic.
Okay.
Dextrose to be cautious, because dextrose is a big problem. It is in vitro, it is okay, but systemically dextrose gets metabolized. So what you get is basically free
only work.
Distribution. If you remember the compartment system, it goes to the industrial compartment too much, leading to cellular injury. It's also not good. The perioperative fluid at 5% is contraindicated unless there is specific indication. I say that in trauma, but neurosurgery the preferred food is probably 0.9%. Osmolarity on the higher normal side. Ringer can bring down osmolarity to an extent. This doesn't. The idea is again to prevent brain cell swelling. Good.
It's a Japanese literature. In the Japanese literature, obviously I haven't read the Japanese literature, but in the standard thing, is HHS giving 5% dextrose when the blood sugar is less than 300, then I'm hearing for the first time.
Yeah, and that's why I said you should take that out from
I'm hearing for the first time. I understand where it is coming from. They want to maintain serum osmolarity. But as Dr. Gupta mentioned, yes, if you're insulin deficient, 5%, the high blood sugar is also give you substantial osmolarity. But you see, that is not the better way of doing it. The better way of doing it is perhaps with sodium, maybe, if you want the high osmolarity. That's why I was mentioning to you, leave the sodium correction for later. Don't need to do it immediately. That's how it is. So, just like when you're correcting sodium, you do it slowly, 8 to 10 millimoles, which is roughly about, if you double it, so 20 milliosmoles per day is what you're basically changing osmolarity. In HHS, treat it as if you're treating osmolarity. So you correct it only say 20 millimoles a day, not more than that. Okay, if you do that, then your patient will perhaps survive. Otherwise, that's the reason why HHS has high mortality. Okay, compared to DKA. People with DKA perhaps should not die from DKA, they can die from the precipitating event of DKA. But HHS has a high mortality largely because people basically bungle up with the fluid balance rate. That's why. So I wouldn't agree with the giving 5% dextrose when the blood sugar is less than 300. But okay, if it is written somewhere, Japanese journal maybe. But that's not how we do it technically speaking. Move on.
Insulin therapy. Regular insulin IV is preferred over subcutaneous because of a short half-life and easy titration. In case of mild to moderate DKA, the rapid-acting insulin analogs like Lispro and Aspart is also quite effective. We will start with a 0.1 unit.
Go back again.
Yes.
So, what's the half-life of regular insulin given IV?
Regular insulin and IV.
So, regular insulin is preferred over subcut because of the half-life. So, what's the half-life of regular insulin intravenous? No idea.
No, sir.
It's only 2 to 3 minutes. So in case of mild to moderate DKA, the rapid-acting insulin analogs is also quite effective. What's the half-life of an IV Lispro or Aspart if you manage to give it to your patient?
2 hours. 2 hours.
Sorry?
2 hours.
No. Again, if you want, you are going to give this IV only. Again, it perhaps is only 2 to 3 minutes. That is the reason why, even though there are newer insulins available in the market, we still give, because if it is almost the same, why you want to use an expensive insulin? You can always give human actrapid intravenously and treat your patients. The companies will always say, they always want to sell more expensive drugs. That's where the problem is. But you have to understand that both these regimens are perhaps equally good.
We'll start with a 0.1 unit per kg body weight as an IV bolus, and then we'll continue with that dose for an hour, or we won't do the bolus and we'll straight away start with 0.14 unit per kg body weight in a continuous infusion for at least an hour. In case of blood glucose not decreased by 10% in the first hour, we'll give a bolus of 0.14 unit per kg body weight, and then the previous treatment should be followed. When the serum glucose reaches 200 mg per deciliter in case of DKA and 300 mg per deciliter in case of HHS, the infusion is reduced to 0.02 to 0.05 unit per kg hour.
Is this what we are using in our ICU? What are we using in the ICU?
No, sir, we no.
DKA patient দেখে ICU তে কিভাবে ব্যবহার হয়? Now, how are you treating these patients?
So we follow protocols here.
বলছো? এসব ক্যালকুলেশন করছিস 0.14 ইউনিট per কিলোগ্রাম of body weight নার্সেস গুলো বোঝে এগুলো?
No.
হ্যাঁ?
We go with the protocols here, sir. Regular insulin protocols here.
প্রোটোকল আছে, DKA এর প্রোটোকল আছে?
No, sir.
নেই। তাহলে কি করছিস? চলো আমরা কি করছি, আমাদের আছে DKA প্রোটোকল, সেরকম তো DKA প্রোটোকল নেই। কি করো বলে দাও, হেল্প করো। হ্যাঁ
0.1 1 unit per kg, IV plus করবে 0.1 unit.
তুমি 0.1 ইউনিট করবে, ঠিক আছে, মানে 0.14 দিতে হবে সেটা কে বলতো, মানে 0.1 দিয়ে ঠিক আছে, 0.1 unit per kilogram বলে, roughly 60 kilogram person or whatever it is, 60 or 70, 0.1. You gave a bolus of 6 units. তারপরে আবার 6 units পর আবার আরম্ভ করে দিবি আইবি, তাই না? তুমি সেটাই তো বলছো।
হ্যাঁ স্যার।
তারপরে কি হবে? 1 ঘন্টা পরে তুমি সুগার চেক করলে কমলো না, কি করবি?
Sir will give a bolus আবার।
You'll give a bolus again, which will, I just mentioned, will you perhaps also agree that bolus will only work for 2 minutes?
Yes sir.
तो फिर क्या होगा? You have to increase the insulin infusion rate. If the blood sugar is not coming down, what do?
We increase the insulin.
So from 6 you want to increase it to say 10 units per hour. That is what you're going to do. ठीक है ना?
Yes sir.
So if you increase it to 10 and then you check, and suppose it's still not come down, then what are you going to do? If something does not work, what will you do?
Will increase.
Sorry?
Will increase the dose sir.
You will increase the dose further.
Or maybe add something else to it.
What will you add? What other drug will lower somebody's blood sugar and stop lipolysis?
It's only insulin.
Only insulin. So you can't add anything. So you can, yes, possibly you may have to double the dose. But what is more important? That what you have done is happening or not is important.
Okay.
Because it's unusual that it will not work. So is the pump connected properly? Is it really going intravenously or not? That is what you have to check. Okay? And if you check that and you find that, okay, fine, everything is going on, fine. Yes, again you may have to increase it to 15 units or 20 units of insulin. But usually you don't need that. Usually there's a problem with the connection. You see, you have to understand, 10 units per hour is how many units in 24 hours?
10 units per hour is how many?
How many units in 24 hours?
2400. 2400.
240 units. Nah. This is what happens in the
Yes,
exams.
sir.
I'm not taking your exam. I'm just trying to make you understand. So 240 units of insulin in 24 hours is a lot of insulin.
Yes.
Because usually on average, how much insulin does a patient need?
0.5.
Maximum of 0.5 units per kilogram of body weight में काम हो जाता है. So if somebody is 60 kilograms, 30 units should do the job. So why it is not working, you must check that what you are giving is connected properly or not. Okay? So by 10 units per hour or something, you will always find that the blood sugar is coming down. Okay. The practical aspects of it is more important than this one. You perhaps will forget because 2 weeks later there will be some other condition where it will be written point something. Then you will forget that there is something called 0.1 or 0.15. Okay. Okay. So move on.
Now we'll go ahead with potassium correction. Establishing of adequate renal function. If potassium is less than 3.3 milliequivalent per liter, the insulin therapy is put on hold and potassium correction is done. If potassium is between 3.3 to 5.2 milliequivalent per liter, 20 to 30 milliequivalent per liter potassium in each liter of IV fluid is given to keep it between 4 to 5 milliequivalent per liter. If potassium is more than 5.2, checking of serum potassium every 2 hours has to be done.
So have you understood this way? Tell me why. See, potassium is less than 3.3, why you want to hold insulin?
So it will further decrease, it will further cause hypokalemia.
But then the patient's DKA will basically also get worse.
Yes sir.
So, what is it trying to tell you? It's trying to tell you that Potassium is a priority because your patient can die suddenly as a consequence of your potassium being less than whatever, 3 or whatever. Arrhythmic death. But will your patient die of a diabetic ketoacidosis if its bicarbonate drops from whatever, 15 to 10 or whatever? It's not going to happen. So potassium correction is important. Suddenly any of your patients can die. That's the reason why you can hold the insulin and correct the potassium. What about the next one? If the potassium is between 3.3 and 5.2, so this is almost normal, you say.
Yes.
Why you still want to give potassium in each liter of fluid? Why you want to, if it is normal, why you want to correct? What are you trying to do?
So if I'm putting the patient on an insulin therapy, so it will decrease the potassium. So we have to maintain it. That's why we have to put in potassium.
So you're still correcting potassium so that you can maintain it in the normal level.
Yes.
Fair. Okay. And the last one?
More than 5.2, it's fairly high. So sir, if we give insulin, it won't decrease that much. So for that we have to check. Yeah, for that we have to check every 2 hours.
Fair. Because you want to see that you're not getting worsening hyperkalemia is what you're trying to do.
Yes.
Because see, this is written in the book. But do you get a potassium value within 2 hours, 3 hours, 4 hours, 6 hours? How many hours it takes for you to get a potassium value in the hospital?
3 hours.
Will they have?
Even they have the stats, their entry machines give it.
No.
But that you
3
can't
hours.
treat somebody with an ABC's potassium value.
No, sir. 2-3 घंटे में.
So, see, traditionally what we used to do is that you're giving somebody potassium, if you're giving somebody insulin and correcting their decay, and if the acidosis is getting corrected, it is expected that the potassium will be coming down. So you don't need to keep checking every 2 hours, honestly. This is overdoing it, honestly.
Okay, sir.
But yeah, there might be room to check it, say in 4 to 6 hours time or whatever it is. You need to check it.
Yes.
The guideline for checking the electrolytes, the guideline for potassium, magnesium phosphate, and
Okay, but as long as you understand why we are doing what we are doing, it is extremely important. Because it's logical and it's scientific. That's the reason why these recommendations are there.
The message is, whatever be the serum potassium, your total body potassium is low. Okay? Because they lose potassium with the diuresis and everything. And why is the serum potassium not always proportionately low? Because of the acidosis and the insulin deficiency. Your intracellular potassium is the major intracellular ion, it comes out. So when you start hydrating the patient, when you start correcting the acidosis, your potassium will go in with the cells. Potassium will drop.
Yes, sir.
So if it is very low to start with, then it will drop to dangerously low level. So you have to first correct it. If it is normal, it will still drop. So you have to correct it. If it is high, it will still drop. So I mean, I would probably start with a little bit of potassium, even if it is 5.2 or 5. Whatever. Unless your creatinine is high, you're not sure the urine output of this.
So one thing it is even wrong is putting potassium less than 3.3, corrections is 20 to 30 milligram per hour per liter.
The per liter, 0.2 per hour.
While actually second with the modern 20 to 30 milligram per liter to first with 20 to 30 milligram per hour.
अच्छा.
You can add to the fluid.
हाँ.
এখানে ব্যাপার আছে তবে কারণ যদি potassium সত্যি একটু begin with 3.3 হয় না, it is disastrous because in decay you are expected to get a higher potassium level, pseudo hypothalamic because of acidosis. Right? So to begin with, if the potassium is 3.3, the total potassium stored in the body
Deficit is
really low. That is why the number point in insulin on hold, because the potassium stored is really low. In decay, getting a hypokalemia is something very dangerous. You expect to get a higher potassium.
Yes.
People think that the potassium is high. 5.2.
हाँ sir.
যখন ইনসুলিন দিচ্ছ পটাশিয়াম কমবে, অ্যাসিড কারেক্টে পটাশিয়াম কমবে। এই জন্য পটাশিয়াম দেওয়াটা বলছে স্যাটিটা বললেন যে মনে রাখবে যে তুমি যখন কারেক্ট করছো গ্লুকোজ এবং অ্যাসিডোসিস, ইট উইল ইটসেলফ ব্রিং ডাউন পটাশিয়াম। সো কিপ অ্যান আই these are total body potassium is definitely on the lower side. So to begin with 3.3 power, then alarm will sound. That is why you treat potassium first.
Yes.
Obviously, simultaneously or some point
True,
of time.
Yes. Bicarbonate correction. When pH is less than 6.9, 100 millimole in 400 ml of sterile water along with 20 MEQ of KCl is infused over 2 hours. This can be repeated every 2 hours until the pH comes over 7. Monitoring of K plus is also done every 2 hours. When pH is more than equals to 6.9, no correction is given, as bicarb correction doesn't add to advantageous outcomes, rather certain deleterious outcomes like cerebral edema, hyperkalemia, reduced tissue oxygenation.
See, again, this recommendation, you're not doing this in your own hospital, are you?
No.
You're giving 100 millimoles of bicarbonate in 400 ml of sterile water. Good shadow. It's a niche scan. This is something a copy for it. I know, but
see the guidelines are on their situation. ওখানে দুটো strength এ bicarb পাওয়া যায়। একটা পাওয়া যায় where you know in particular situation এ whereas the other is actually a much higher thing. We can give it neat and a syringe possible.
That's what we do. So that's what we should write down what you do technically speaking.
মানে আন্ডারস্ট্যান্ডিংটা ক্লিয়ার রাখতে হবে যে গাইডলাইনটা বলেছে ওই কনটেক্সট ওদের কারণে এটা পাওয়া যায় ওটা পাওয়া যায় এরকম ভাবে দেয় কেন স্যার সেটা
6.95 হলো quarterly bicarbonate.
So have we moved from following the Americans to following the Japanese?
No, that was just a
This is definitely.
ঠিক আছে।
Phosphate.
Okay, we got 7 level. Look at 7.1, 7.5. They feel to give bicarb. It's very simple. Threshold is better जाएगी.
Yeah, somewhat to follow in the it is not much evidence that it does any good, but less than 7.2 will do okay.
Mortality was the same, but
Yeah,
given the point.
ডাক্তারের anxiety-টা কমে যায়।
Raise it up to 7.2 is probably okay, but
I mean, you see, the problem is that when you next check the ABG, and then you get a false sense of security from the pH, from the acidosis. So your যেরকম হয় না যে p time to acid liver disease আমরা দিয়ে দিলাম FFP. The next time you measure your p time is normal, but then it no longer remains a valid marker of the corrosion. It's the same situation.
High dose of vasopression থাকলে একটু threshold একটু না কমিয়ে যে একটু radiotherapy শুরু করতে হবে, but nobody waits for 7 to 9 but
In decay, if you are hemodynamically unstable, then you definitely need to correct the bicarb. But otherwise, your bicarbonate will be corrected by the treatment of decay itself. Okay. So, because if you overzealous bicarbonate infusion will have basically very intracellular acids. So, and as Dr. Gupta said, you perhaps are not getting an understanding of is the acidosis, the process of acidosis corrected because of the fact that you've already given so much bicarbonate. So you avoid giving. That's how it is different from others. See, your potassium of 5.2, I have seen that people have been correcting potassium levels in the ICU. But in DKA, you're not attempting to correct the potassium in that fashion. You're just basically giving them insulin and fluid, and that's what is happening.
Yes,
So
sir.
the context is important. Okay? The context is different.
Phosphate correction. Insulin therapy decreases serum phosphate. Overzealous.
Roughly 400 mg per atmosphere potassium of phosphate 3 millimoles per.
So should I proceed? So this is the entire management in the form of a chart. The same things I have said before. So I'll move forward. So now we move on to the resolution part. In DKA, when the blood glucose is less than 200 milligram per deciliter and any two of the following is seen, where the pH is more than 7.3, serum bicarb is more than 15 milliequivalent per liter, and an anion gap of less than 12 milliequivalent per liter. In HHS, normal osmolality is achieved and there is a regain of mental status. We can fairly say that the states have resolved. So after we cannot continue this regular insulin infusion for a very infinite period of time, so we have to transition to subcutaneous insulin. So transition of this regular insulin to subcutaneous insulin is done with an overlap of 1 to 2 hours. Patient who are in nil per mouth must continue with the regular insulin infusion and fluid replacement.
So what does that mean?
Sir?
So transition of regular insulin to subcutaneous insulin is done with an overlap 1 to 2 hours. So what will you do?
Like what I'll give.
What will you do? What instruction will you give to the nurse? What does that statement mean? What does it say? What will you do? Overlap. So
Continue regular insulin.
no, infusion is going on. Now the patient is well.
Yes, sir.
Okay, and now you want to put him on subcutaneous insulin. Isn't it? So what are you going to tell the nurse?
इंसुलिन
Patient
चल
will
में
have
तो
lunch.
हाँ तो
So then insulin subcutaneous को भी देवे.
हाँ फिर then we'll see the CBG and then we'll see for 1 to 2 hours and then we'll stop.
And then stop the insulin later.
Yes, sir.
At least 1 hour or 2 hours later.
Yes, sir.
Why is that? There must be a reason why something like this you have to do. No?
Yes, sir.
What is the reason?
Rebound hyperglycemia. Subcutaneous ambulation of the time that the effect of body আছে তার আগে যদি আমি ইনসুলিন ইনফিউশন বন্ধ করে দিই রিবাউন্ড hyperglycemia.
See, the reason is subcutaneous insulin, the effect peaks at around 2 to 3 hours. Okay, unless you use an analog insulin, which can be faster. So even though you have given subcut and you stop the IV, so there will be a roughly about 3 or 4 hours gap, and as you mentioned earlier, DKA can basically precipitate very quickly, rapidly compared to HHS. Okay, so presumably you have not seen, but I have seen several patients. DKA seems to get better, goes back into DKA. So that is one problem that happens. Okay, so that is the reason partly why. So you need an overlap. Okay, and these patients are all insulin resistant, so there's no risk of developing hypoglycemia. And you may worry that you're giving IV insulin and subcut insulin. Don't need to worry. Basically, that is the scientific explanation. So you give them the subcut insulin, and you can ask your nurse to continue the insulin IV. And because anyway, you're basically sometimes checking these patients' blood sugars every hour, so there's nothing to worry about.
Yes. Patients with type 2 diabetes mellitus can be put back to their old regime. In insulin naive patients, a multi-dose insulin regimen should be started at a dose of 0.5 to 0.8 unit per kg per day with NPH and regular insulin in 2 to 3 doses per day. Basal bolus regimens with basal glargine or detimir and rapid-acting insulin analogs Lispro, Aspart, Glulicin has been proposed and seems to be causing less hypoglycemic episodes as compared to NPH and regular insulin in type 1 diabetes mellitus. Complications. Hypoglycemia and hyperkalemia due to aggressive treatment with insulin and bicarb respectively. Cerebral edema. Cerebral edema most commonly is seen in children and extremely rarely seen in adults. It happens due to the rapid correction of DKA. Symptoms are degrading GCS, loss of sphincter reflex, seizures, papilledema, bradycardia, hypertension, and respiratory arrest.
So I'll just stop here. This is just something which my son is a doctor as well, and I taught him about DKA. So in adults, you basically give them IV insulin and IV fluid perhaps simultaneously. But in pediatric population, because of the risk of cerebral edema, you generally don't give both of them simultaneously to start with. You give one first and then the other. Okay. By just giving IV fluid, you can lower the blood sugars. Is that right? So you can lower the blood sugar. So you give IV fluid first, and an hour later you can start the insulin. I mean, there's again, it just tells you there's no rush to start the insulin straight away. I mean, you can wait because DKA sort of happens over a period of time. Okay, so it is not that important. So there was a neat PG MCQ where several options were given, and I taught my son the wrong thing because what they said was, how would you give the IV fluid and insulin according to ISPAD guidelines? ISPAD is nothing but a pediatric association guidelines. Okay. So you give IV fluid first, and then you perhaps give insulin. Okay, so that's how it's different. Cerebral edema in children can be a big problem. I mean, the percentage of patients developing it is much higher than adults.
So the mechanism is brain adapts to decay by creating osmoles and preventing the brain, in order to prevent the brain from shrinking. When the hyperosmolarity is rapidly corrected, the brain becomes hypertonic and the water is drawn inside the brain, causing cerebral edema. Prevention, by simply avoiding the rapid correction of dehydration and plasma osmolality, keeping the blood glucose between 250 to 300 till the plasma osmolality is corrected gradually. Treatment is mannitol infusion and ventilation if required. Prevention of DK and HHS. Early contact with a healthcare worker, emphasizing the importance of insulin during illness and never to discontinue it. Reviewing blood glucose goals and providing with short and rapid acting insulin. Sick day rules, which are these. S is sugar. Check your blood glucose every 2 to 3 hours. Necessary more frequently in pregnant women and children. Always continue to take your insulin even when you are sick to avoid decay. Carbs, make sure you take in enough carbs and drink enough fluids. If your glucose level is high, stick with sugar-free drinks. If your glucose level is low, drink carb-containing drinks. Ketones, checking your blood or urine ketone level every 4 hours. Taking rapid-acting insulin if ketones are present. Remembering to drink plenty of water to flush out the ketones out of your system. So with this, thank you, sir.
This is going to be endocrine month. Yeah? Endocrine month. What is the
See, when you perhaps are reviewing, say, literature, say, for metabolic diseases, so you have major diabetes associations globally. Okay, if you tap those, they will give you more practical way of treating these patients. This is not an easy way to treat the way it is written 0.14 and adding water to this thing. It's not what you really do. So if you look at how to treat DKA, either say at Diabetes UK or American Diabetes Association, or even if you want to basically look at WHO guidelines or IDF, there's something called International Diabetes Federation guidelines, okay, which is accepted globally. You will have a much more practical and a more pragmatic way of treating these conditions, okay, rather than something else.
Yes, sir.
So that's what you should perhaps look at, and that will also give you a flavor of perhaps what the latest is, because all these guidelines have annually they have updates or they have changes or something like that. I presume the same is with say treating COPD, asthma. The Respiratory Association guidelines would be perhaps more relevant and more practical rather than something like this. It's also, it explains you well, it's easier to understand. Okay. And sometimes these articles don't give you explanation as nicely as perhaps the ADA or the Diabetes UK would be.
So in the same line as you mentioned, you see, we are not used to having a lot of patient associations here. But for many of these diseases, there are very strong patient associations. I remember the first time I was working for somebody and we had some cystic fibrosis patients. My then boss said that you must attend this particular meeting. And he said, I'll pay for you to go and stay, etc. So I went there and basically it was the Cystic Fibrosis Association, and half the people in the audience were cystic fibrosis patients. Half the speakers were cystic fibrosis patients. And they are the ones who can actually teach what is wrong with them, how it should be done, now there's that. It was very uncomfortable for me because that was for the first time I was attending a meeting where, you know, it was these...
you know little.
Yeah, I mean, it was eye-opening. But then as you do this, you get more comfortable. So, and a bacha, say school, you have a cope way, etc. Your associations, you will get a lot of practice. I mean, it doesn't apply to GK, maybe it's in a hospital. But information, similarly, there are asthma associations. Rare diseases, to also in like diabetes, to true also. Thank you.
There's the net and the books, there's so many, the information overload. So you now need to learn which is perhaps the best and appropriate site that you need to see and basically take their recommendations. Okay, because I'm sure in another 10 years' time that even there'll be much more data on the net. So there'll be a lot of misinformation as well, or not misinformed in that fashion, but not easy to digest information. It's very difficult. Okay, nice, yeah, good. But always ask yourself why that recommendation is there. Because there must be a scientific explanation.
Yes, sir.
You should have